Thanks everybody for tuning in tonight for this educational event. We've now heard about shoulders, we've heard about hips and knees. Now we're going to move down the stream a little bit to the ankle. And so I'm going to talk about ankle arthritis. How do we know when we have ankle arthritis? When do we know to see a specialist, and what are some treatment options? Okay, I'm not advancing here. There we go. So really quick, just want to talk about our group that's part of the OrthoAlliance partners. Our group is the Orthopedic Foot and Ankle Center. It's in Columbus, Ohio. It's the first practice to specialize 100% in foot and ankle. So that's really all we do. We have offices in Worthington, Dublin, Gahanna, Grove City, and Zanesville, just all in Central Ohio. We have in-house PT that's part of the OrthoAlliance physical therapy network that's really throughout Central Ohio and beyond, which is great for patients and convenience. We have an in-house MRI that just does foot and ankle, so it's the foot only goes in. We have weight-bearing CAT scan. We actually have a store to help with any of our patient needs. We're dedicated to education. We train residents. We have fellows every year, and we're dedicated to research. And three of our physicians are basically help design some of the current total ankle replacement designs that are FDA approved. So when we look at ankle arthritis, a little bit different some of the other joints that we heard about, from the standpoint that, yes, people will have primary ankle arthritis, the wear and tear. They'll have inflammatory, which includes rheumatoid arthritis, but post-traumatic by far in the ankle is the most common. So these are people that have had fractures, have had traumatic episodes, have had long-standing ankle instability. So that's going to be the most common patient that we're seeing for ankle arthritis. When do you know that you need to see a specialist? Well, when you start having these symptoms, that's probably when you need to do it. So if you're taking less steps, you're avoiding doing things, it's interfering with activities, you slow your walking speed, you basically have diminished ankle push-off. And when your stiffness and your pain alters your gait, it can affect the entire chain. So it can start to bother, not only your ankle, other parts of your foot, your knee, your hip, all the way up the chain, just because of how altered your biomechanics are. And from a physical impairment, it's actually interesting. There's been studies that have shown for ankle arthritis that it can actually equal some of the major medical disorders that have impairments, such as end-stage renal disease and congestive heart failure. So how do patients present? Typically, they're going to have pain, usually worse with weight bearing and activity, stiffness, perhaps worse in the morning. They're going to feel like they're losing motion, and they'll have crepitation, which basically is popping almost like Rice Krispies in the front of your ankle, and you'll see this a lot of times in the joint. When you come to see us, one of the things we want to do is we want to try to understand what activities aggravate your pain, which things make it worse, which things make it better, and try to exactly pinpoint where your symptoms are. So when you're in the office, we're gonna check everything. We're gonna look at the front of your ankle, the back of the ankle, ligaments and tendons, but also make sure that it is the ankle that's the issue and not other joints, like one of the most common joints called the subtalar joint, which is right below your ankle. We're gonna assess your range of motion or lack of motion. X-rays are going to be really important. We've kind of heard this from everybody. Weight-bearing X-rays are going to be really, really important. And if you look here on this X-ray, we heard this from everybody, but you can't see cartilage. You see the space where the cartilage lives. And if there's no space, there's no cartilage. And that's essentially what arthritis is. So if you look over here, you can basically see on the joint here on the right that there's very little joint space. And that just means that basically the cushion has been lost between the joint. As far as CAT scan can be an important thing to really help us understand deformity, understand which joints are most affected. And we offer a weight-bearing CAT scan, to my knowledge, is one of the only in Central Ohio. And it's great because it's great for preoperative planning. It helps us to look at arthritis in 2 and 3 dimensions. And for the kind of ankle replacement I use, it's a patient-specific one. The weight-bearing CAT scan is very important. Other things to look at, MRIs. MRIs are going to show us more soft tissue. They're going to show us cartilage, ligament, and tendons, and things like that. So we've heard this before, same thing in the foot. What are our goals? Relieve pain, prevent further deformity, and try to improve function. When we look at some of the list of treatment, basically we've heard about different medication, anti-inflammatories. We're going to talk about some bracing. There are different injections. There are PRP injections, unfortunately, usually not covered by insurance and can be expensive. The other thing that's out there is doing steroid injections. Again, it's something that can buy you some time, but it's not really a cure. And when we look at visco supplementation, this is something that there's some studies in knee that are favorable, others that are not. But the bottom line is it's not really an option in the ankle because it's not FDA approved for the ankle. When we look at bracing, this is a kind of a brace we call an AFO, an ankle foot orthosis. It can be helpful in the right patient. Another potential brace is this one here. It's a lace-up brace that's actually custom. It's called an Arizona brace. When it comes to bracing, it can certainly be an alternative to surgery, but it's probably best reserved for an older, more sedentary population from just a tolerability standpoint. When we look at surgical things, there's a lot of different things that can be done. We can go in arthroscopically, remove spurs, clean out the joint. It's definitely not a cure for arthritis because, as we heard, there is no real cure. And these are for people that have low-grade arthritis. The surgical options for end-stage arthritis are going to be ankle arthrodesis, otherwise known as fusion, and also an ankle arthroplasty. A lot of people say, well, I didn't know you replace ankles. And it is something we do, and we're really in the third and fourth generation, and the results continue to increase year by year. So ankle fusion is a good operation. It's stood the test of time. It's been around since the early 1900s. People can do very well, again, in the right patient. Basically, people get, sometimes they get freaked out when you say you're going to fuse the joint, and they're like, well, how am I going to walk? Well, what you have to understand is that when you have end-stage arthritis, you've lost most of your functional motion, and it's the motion that's left that's a pain producer. So they can do quite well. One of the downsides to having a fusion is that the joints that are just around that area usually will take on more wear and tear, and those things can eventually lead to arthritis, potentially requiring other treatments in the future. So obviously you're going to lose that motion, but some people still may have up to 40 to 50% of dorsiflexion, which is actually coming from a different joint. They'll lose about 16% of their walking speed, and overall they will consume a little bit extra energy after having a fusion. What about ankle replacement? If you look generally at the outcomes compared to a fusion, most of the literature shows that the range of motion and gait is going to be better in total ankle patients compared to fusions. But basically, it still can't say that it's really normal range of motion. The indications for this, patient selection is key. You want to make sure that your patient's expectation meet your expectations. It's not something that's for everybody. Generally speaking, we want to do it in people that are 50 and older because, like we've heard with the other joints, they do not last forever. We sometimes want to consider this in more low-demand people. And what I mean by that is if you're somebody that's lifting a lot of heavy weight, if you're someone that's on ladders, someone that's on a telephone pole, for example, this is someone that's maybe too high demand to consider an ankle replacement. And then we want to avoid people that have excessive weight. Things to avoid in a total ankle replacement, people that have a thing called talar AVN or avas necrosis, which basically means bone death or lack of blood supply to the bone, people that have neurologic compromise or neuropathy, people that have had infections, and people that are generally weigh more than 300 pounds. So again, looking at the literature, if you look at some of the early things in the first 3 to 6 years, 70 to 90% survivorship, and now getting in 8 to 10 years, 80 to 95. I have many patients in my practice that have had a total ankle replacement in for anywhere between 10 to 20 years and are still progressing well at this time. So I'm going to go over some quick little cases here just to kind of illustrate some things. So this is a 52-year-old female with a history of a pilon fracture, which is basically a fracture at the end of the tibia that affected the joint. And even though this is put together very well, sometimes you just can't really save the joint and people end up getting arthritis. So here's what her ankle looks like about 6 months after surgery. You can see a lot of the space that she has in that area. And then if we fast forward to 1 year and 7 months, again, looking at things, and ultimately about that time frame, one of her goals was to get back and try to do a half marathon. She was able to return back to a half marathon. She walked and ran it. It wasn't a full run, but she was able to do it, and it's something that she simply could not have done prior to surgery. Another quick case, 62-year-old failed bracing in the past and steroid injection. You can see there in the x-ray, very little joint space. Subsequently had surgery. If you look at this video, basically you almost can't even tell which ankle has been replaced because the gait looks so good. And this patient has been very pleased, and he's probably at this point about 2 years out. Just another quick view, again, showing the motion that the patient has, and it's good free range of motion. And again, illustrating that, ankle replacements do exist and they can do very well. As far as after surgery, what to expect, most patients are non-weight bearing for about a month. And then for another month, they're in a boot and they start therapy. We like to get therapy going as quickly as we can. We really can't do it in the foot and ankle until, we have good soft tissue healing, and that the swelling is starting to come down, but, non-weight bearing for a month, and then typically in a boot for a month, and then progressing there. And most of our studies show that people continue to improve even up to a year or 2 years after the surgery. The big question is, what activities can they do? And so, one study has showed that after patients have had a total ankle replacement, that 65% were able to get back to doing increased sports activities. One study showed a lot of those patients do light reaction and non-impact sports. Another study basically showed that before surgery, they were about 36% active, and then after about 56% active. And some of the things that they're doing are like hiking, biking, and swimming. And then another recent study that basically looked at people getting back to pickleball, which is a huge thing nowadays. And the majority of patients were able to get back to pickleball at a very high level.